If amlodipine is in your pill organizer right now, there are 5 specific things that interact with it in ways most prescription conversations never cover. And at least one of them is something you have probably done this week without a second thought. Not because anyone is hiding this information, because the appointment where amlodipine was prescribed covered the dose, the purpose, and perhaps one common side effect, and moved on to the next item on a list that was already running short on time. What did not get covered is what happens when amlodipine meets a piece of fruit, a missed week of doses, a long queue at the post office, a tablet for a sore knee, or a decision made quietly at home to simply stop taking it. Each of these 5 things, individually, sounds completely unrelated to a blood pressure medication. Together, they are responsible for a significant proportion of the amlodipine-related complications I see in adults over 60. Amlodipine is one of the most commonly prescribed antihypertensive medications in the world, a calcium channel blocker that relaxes the smooth muscle in arterial walls, reducing the resistance against which the heart pumps. It is effective, well-studied, and generally well-tolerated. But its mechanism, relaxing arterial smooth muscle through calcium channel blockade, interacts with specific substances, behaviors, and decisions in ways that are predictable, documented, and almost never discussed at the point of prescription. Research reviewing amlodipine-related adverse events found that a significant proportion were not due to the medication itself behaving unexpectedly, but to one of 5 specific factors that altered how the medication behaved in that particular person on that particular day. My name is Dr. Nicole Harper. Before we continue, do not stop, reduce, or change your amlodipine dose based on this video without speaking to your prescribing doctor. Everything described here is information to discuss at your next appointment, not a decision to make independently. I am going to describe 5 specific things to avoid, the mechanism behind each one, and what to do instead. Stay with me through all 5, because the 5th one is the one most directly connected to the first 4, and understanding it changes how you think about the other 4 entirely. I want to tell you about a patient I will call Reginald. He was 75, a retired postal worker, a creature of habit, proud of his routines. He had been on amlodipine for just over a year. Over a period of about 10 days, several things happened that seemed unrelated to him at the time. We will come back to Reginald throughout this video, because by the time he came to see me, 3 of the 5 things I'm about to describe had all occurred within the same short window, and together they had produced a blood pressure reading that frightened him and a hospital visit that was, in the end, entirely avoidable. 5 things. Before I go through them, I want you to notice something as we go. None of these 5 things on their own sound dramatic. A piece of fruit, a missed dose, a long queue, a tablet for joint pain, a decision made quietly at home. That ordinariness is exactly why they matter, because nothing about any of them triggers the sense of caution that a person would naturally apply to something that felt dangerous. Give me a few minutes. By the end, I think you will see why each one deserves more attention than it currently gets. Thing 1. Grapefruit and grapefruit juice. Amlodipine is metabolized in the liver by an enzyme called CYP3A4. Grapefruit and grapefruit juice contain compounds called furanocoumarins that irreversibly inhibit this enzyme. When the enzyme responsible for breaking down amlodipine is inhibited, the medication accumulates in the bloodstream at concentrations significantly higher than the prescribed dose was designed to produce. Research has documented that a single glass of grapefruit juice can increase amlodipine blood levels by 30 to 90%, depending on individual CYP3A4 activity and the quantity consumed. Think of CYP3A4 like the exit door through which amlodipine leaves the body. Grapefruit locks that door. The medication that should be leaving accumulates instead, to concentrations the prescribing dose never intended. The symptoms of this accumulation are the same symptoms listed as amlodipine side effects on the package insert: dizziness, flushing, palpitations, headache, and the ankle swelling described under Thing 5. Many patients experiencing these symptoms have been told they are simply sensitive to the medication, when the actual cause is a food interaction producing an unintended dose escalation. The interaction applies to whole grapefruit, grapefruit juice, and any drink listing grapefruit as an ingredient. Seville oranges carry the same risk through the same compounds. Sweet oranges, lemons, and limes do not contain furanocoumarins and are safe. What to do instead? If you are taking amlodipine and consuming grapefruit in any form, stop today and mention it to your pharmacist. The same CYP3A4 interaction applies to many statins and other common medications, so a full review is worthwhile. Today, not next month. That is the interaction most people have never heard named. The second thing on this list is one your instinct will tell you is the responsible choice. And your instinct, in this specific case, is wrong. Stay with me. Because the mechanism behind thing 2 is the one that explains why some of the most frightening blood pressure readings I see happen not while a patient is taking their medication irregularly, but in the days immediately after they decide to stop. Thing 2. Stopping amlodipine abruptly. Amlodipine works by relaxing the smooth muscle in arterial walls, keeping the arteries in a more dilated state than they would otherwise maintain. Over months of consistent use, the arterial smooth muscle adapts to this chronic dilation. When amlodipine is stopped abruptly, whether due to a side effect, a decision to try without medication, or simply running out and not refilling promptly, the arterial smooth muscle does not immediately return to its pre-treatment baseline tone. Instead, in a proportion of patients, it responds with rebound vasoconstriction, a constrictive response that can temporarily overshoot the pre-treatment baseline, producing a blood pressure surge that is higher than the blood pressure the person had before ever starting the medication. Think of arterial smooth muscle on amlodipine like a spring that has been held in an extended position for months. Release the tension suddenly, and the spring does not simply return to its original length. It can overshoot, contracting more tightly than its original resting state before settling back. The blood pressure surge from abrupt amlodipine discontinuation can occur within 24 to 48 hours of the missed doses, and in adults with existing cardiovascular disease, this surge carries genuine stroke and cardiac event risk during the rebound window. What to do instead? If amlodipine needs to be stopped for any reason, a side effect, a planned medication change, anything, that decision should involve your prescribing doctor, who can advise whether a tapering approach or an immediate substitute medication is appropriate. Never simply stop and wait to see what happens. The seeing what happens window is exactly when the rebound risk is highest. Thing 3. Standing motionless for long periods. This is the one most people have never connected to their medication at all. Amlodipine's vasodilation effect is not uniform across the circulation. It preferentially dilates the small arteries feeding the capillary beds in the lower limbs more than it dilates the veins draining them. Standing still, in a queue, at a church service, at a long checkout line, working in the garden without moving the legs, relies on the skeletal muscle pump in the calves to assist venous return from the legs back to the heart. Walking activates this pump with every step. Standing motionless does not. Combine amlodipine's preferential arterial dilation with the absence of the calf muscle pump, and blood pools in the lower limbs more readily than it would in someone not taking the medication. The consequence is twofold. First, dependent edema, the ankle and foot swelling that worsens specifically after periods of prolonged standing, distinct from the swelling that occurs simply from the medication's baseline effect. Second, and more seriously, in susceptible adults, particularly those who are also dehydrated on other blood pressure medications or prone to orthostatic changes, the combination of pooled blood in the legs and a sudden change in position, such as suddenly walking after prolonged standing, can produce a transient drop in blood pressure significant enough to cause lightheadedness or fainting. Think of the circulation on amlodipine during prolonged standing like a dam where the inflow has been widened, but the outflow pump has been switched off. Water, blood, accumulates behind the dam. When the pump suddenly switches back on with a change in position, the redistribution can be abrupt enough to produce a momentary drop in the pressure reaching the brain. What to do instead? If you know you will be standing for an extended period, a long queue, a service, sustained gardening, shift your weight periodically, flex your calves, or take a few steps every few minutes. This activates the calf muscle pump and prevents the pooling from accumulating to the point where a position change becomes destabilizing. If you do need to move suddenly after prolonged standing, getting up to walk after a long church service, for example, pause for a moment with your hand on something stable before walking. That brief pause gives the circulation a moment to redistribute before the demands of walking begin. Tell me in the comments right now, have you ever felt lightheaded after standing for a long time and then suddenly moving? Type yes if yes, because thing 4 is the one that operates through a completely different mechanism from anything described so far. Not an enzyme, not a rebound, not a circulation effect, but a direct chemical interference with the medication's core action. And it is sitting in almost every medicine cabinet in the world. If this video is giving you something to act on, tap subscribe. Most people watch this video and forget this channel exists by tomorrow morning. If this mattered to you, 1 second is all it takes. Thing 4. Regular NSAID use. Ibuprofen and naproxen, taken regularly for joint pain, back pain, or general aches, interfere with amlodipine through a mechanism distinct from the kidney and potassium concerns that apply to ACE inhibitors and ARBs. NSAIDs work by inhibiting prostaglandin synthesis. Prostaglandins perform multiple functions in the body, including a role in kidney sodium handling and in maintaining the vasodilation that blood pressure medications are working to achieve. When prostaglandin synthesis is inhibited by regular NSAID use, the kidneys retain more sodium and water than they otherwise would, directly counteracting amlodipine's blood pressure lowering effect. Additionally, prostaglandins contribute to the vasodilation in some vascular beds, and their suppression by NSAIDs can blunt amlodipine's vasodilatory action directly at the arterial wall. Research has consistently found that regular NSAID use measurably reduces the effectiveness of most classes of blood pressure medication, with calcium channel blockers like amlodipine among those affected, though generally to a lesser degree than ACE inhibitors and ARBs. The practical consequence? A patient on a stable amlodipine dose who begins taking ibuprofen regularly for a new joint pain may find their blood pressure readings creeping upward over the following weeks, and may never connect the change to the over-the-counter tablets they have been taking for their knee. Think of amlodipine's blood pressure effect like water flowing through a pipe that has been widened. Regular NSAID use is like a valve partially closing downstream. The pipe is still widened, but the flow through the system is being constrained by something the original widening did not account for. What to do instead? If you need regular pain relief and are on amlodipine, paracetamol is the first-line alternative that does not carry this interaction. If NSAIDs are genuinely required regularly for a chronic condition such as osteoarthritis, this should be a specific conversation with your doctor rather than a decision made silently with an over-the-counter purchase. Topical NSAID gels and creams applied directly to the affected joint deliver much lower systemic concentrations than oral tablets and carry a substantially reduced interaction risk, and are worth discussing as an alternative for localized joint pain specifically. Thing 5. Stopping due to ankle swelling without telling anyone. This is the one that connects directly back to Thing 2, and it is the single most common self-directed amlodipine discontinuation I encounter. Amlodipine-related ankle and leg swelling, produced by the preferential arterial dilation described under Thing 3, is uncomfortable, visible, and for many adults, embarrassing. It affects how shoes fit, how trousers sit, how legs look in warm weather. And because nobody explained the mechanism at the time of prescription, many patients conclude on their own that the swelling means something is wrong with their heart, their kidneys, or the medication itself, and quietly stop taking it, often without telling their prescribing doctor, planning to mention it at the next routine appointment, which might be months away. This is precisely the scenario that Thing 2 describes. The abrupt discontinuation, driven by a side effect that was uncomfortable but not dangerous, triggers the rebound vasoconstriction that can produce a blood pressure surge exceeding the pre-treatment baseline. The patient has stopped a medication because of a visible, manageable side effect, and in doing so, has created an invisible, more dangerous one. This is what happened to Reginald. He had noticed his ankles swelling over several weeks, found it uncomfortable and slightly embarrassing, and decided to stop taking his amlodipine, reasoning that he would mention it at his appointment the following month. 6 days later, he developed a severe headache and felt unwell. His home blood pressure reading was significantly higher than any reading he had taken in the year since starting the medication. He had not realized that stopping the medication that was causing the swelling he disliked would produce a rebound effect more concerning than the swelling itself. What to do instead? Ankle swelling on amlodipine is common, usually manageable, and rarely a reason to stop the medication entirely. There are often alternatives, including a dose adjustment, a different timing, or an additional medication that counteracts the fluid shift, all of which require a conversation rather than a unilateral decision. If you have stopped amlodipine because of swelling, or are considering it, call your doctor's office this week, not at the next routine appointment. Describe what you noticed and what you did. The conversation is straightforward. The alternative, the rebound effect thing 2 describes, is not. Reginald's blood pressure on presentation was significantly elevated, consistent with rebound vasoconstriction following 6 days without his medication. He was restarted on amlodipine, his blood pressure normalized over the following days, and at his follow-up appointment, we discussed the swelling that had prompted the original decision. A small dose adjustment, combined with the leg elevation protocol described in the Nocturia video in this series, reduced the swelling to a level Reginald described as barely noticeable. He told me, "I thought stopping was the safe choice. Get the swelling under control, then go back to the doctor when I had time. I did not know that stopping was the thing that was actually dangerous. The swelling I could see. The other thing I could not." 5 things. A piece of fruit. A missed week of doses treated as a pause rather than a medical decision. A long queue navigated the same way it always has been. A tablet for a sore knee taken without a second thought. And a side effect that seemed like a reason to stop rather than a reason to call. None of these 5 things look dangerous in the moment. Each one, individually, is the kind of decision most adults make multiple times without ever considering their blood pressure medication. Amlodipine works by changing how your arteries behave, gradually, continuously, every day it is in your system. The 5 things in this video are the 5 ways that gradual, continuous relationship gets disrupted without anyone noticing until the disruption becomes a symptom. None of them require you to be more cautious in general. They require you to know these 5 specific things. Now you do. One final detail. If you are due to have any medical procedure, including dental work, that may involve fasting or a change to your normal eating and medication routine, ask specifically how your amlodipine should be managed on that day. Fasting changes hydration status, and combined with amlodipine's vasodilation, can increase the risk of the lightheadedness described under Thing 3, particularly if the procedure also involves sitting or lying still for an extended period followed by standing. This is a 5-minute conversation with the practice beforehand that prevents a problem during or after the appointment. Ask before the day, not on the day. Which of these 5 things was new to you? Tell me in the comments. I read every single response personally. Share this with someone on amlodipine who has ankle swelling they have been managing quietly, or who drinks grapefruit juice with their morning tablets, or who has ever stopped a dose and decided to mention it later. In the next video I am publishing, I am covering the 5 things to avoid if you are taking lisinopril, including one interaction that is the mirror image of something described in this video. You will want to see that if lisinopril is part of your routine too. Most people watch this video and forget this channel exists by tomorrow morning. If this mattered to you, 1 second is all it takes. This is Dr. Nicole Harper. 5 ordinary things, 1 medication. Now you know all 5. I will see you in the next one.